Thank you, Dr. Stiff and the Leukemia Research Foundation for inviting me back for another year. I really enjoy this forum and all the great questions we get and the dialogue we get to have with our patients, which is, gives us a lot of unique insights. So I'm going to focus in the next 20 minutes on myelodysplastic syndromes and try and show you a little bit of how we kind of break down treatment approaches in this. MDS is a highly heterogeneous disease because, as the name implies, myelodysplasia means that the cells are dysplastic, which means that they are not maturing as they should be. So when we think about a progenitor cell, which is our original, do I have a pointer? Any chance? Do I have a pointer? Just the mouse. Okay, fine. So when we look at the primitive stem cells, they have the ability to become a mature red cell, white cell, or platelet, depending on which genetic program they undertake. And if there are mutations in this genetic program, they get stuck, sort of developmentally arrested in the marrow. And it can have a number of manifestations clinically, which have to be dealt with differently. So just to reiterate what Dr. Stiff said, this is a disease of the aging population. This is the SEER data showing you that really the prevalence of this, incidence of this disease goes up in the 70-plus population, and the incidence goes from 5 per 100,000 to really over 50 per 100,000 as you get into the late 70s and early 80s. And this is something that has to be borne in mind as we come up with treatment approaches for these patients. It is the most common myeloid neoplasm, so we do see a fair amount of it. I like this slide because it really summarizes very nicely how heterogeneous the clinical outcome of MDS patients can be and how we really have to be targeted in a clinical way when we approach these patients, because it's definitely not a one-size-fits-all approach. So this kind of depicts 100 patients that are diagnosed with MDS, let's say hypothetically this year in the United States, and how their lives will pan out. Because, you know, when you get the diagnosis, you kind of want to know what do I expect. And so just kind of starting at the lowest part of the figure, the first 29 patients in the light blue color are patients that will die of unrelated conditions, so geriatric causes. So these are patients that you could quite safely monitor. And, you know, to answer the whole topic I was given about when is treatment needed, for these patients, potentially, they could undergo observation for a very long period of time. Then the next group, the purple group, is the other extreme. These are the 24 patients that will progress to leukemia. And out of these, 2 of them who get aggressive treatment followed by transplant will survive. And that's just kind of indicating that once MDS progresses to AML, the outlook is pretty bleak. And so even therapies as aggressive as transplant, while they benefit people, but it's limited. So that's definitely the population you want to do something about, and ideally want to prevent your patients getting to that. 7 patients will die in the light gray of anemia-related complications, 20 of infection, in the light blue related to low white blood cell count. The 2 in brown are the ones who are going to die of iron overload. We'll talk a little bit about that. 12 will die of hemorrhage, bleeding complications linked to low platelets. And then the first 6, now these are patients who present to you with high-risk disease, which means they're sort of at risk of transforming to leukemia. And so these patients, 2 of them will be, 6 of them will undergo transplant, out of which you can cure 2 of them. So the success of transplant at this stage of disease is a lot higher, just kind of underlining the fact that transplant should be an earlier consideration in these patients rather than waiting for transformation. So talking about prognosis in MDS, right? So these patients, like I just showed you, can do very variably. And so how do we figure out when we're seeing you in the clinic, which group you'll fall in? So the revised international prognostic scoring system was validated on over 7,000 patients in 2012. And incorporates a number of clinical parameters, including the chromosomal makeup, which is what we call cytogenetics of the bone marrow cells, the percentage of blasts, which are the immature cells that when they expand, change the diagnosis to leukemia, the actual blood counts. And it's not just whether you have anemia or low platelets, it's the degree of it, which is important. And then in a paper that came out around about the same time, which was sort of a kind of a game changer in the field, they looked at individual gene mutations that had been reported in MDS in a very systematic way in over 800 patients with MDS. And they analyzed them for 104 different mutations to see that The scattered reports, how did they pan out in a large cohort, and did they add anything to the clinical predictors of prognosis? And they found that 5 of the genes, and remember they sequenced 105, 5 of them were clinically additive to the clinical prognostic markers. So they did change how a patient did, even keeping all these other variables in mind. So if you had one of those 5 genes, and those 5 genes are P53, RUNX, ASXL, and EZH2 and ETV6. So the low risk patient in the looking at the survival curves in the lower panel A, the low risk patient is the gray dotted line, which when you add on a mutation drops to the green curve, which is an intermediate 1 risk. So you basically drop a curve, and similarly the intermediate 1 drops to 2 and the intermediate 2 drops to high risk. So it added to the clinical prognostic markers. So genetic information is adding to our ability to predict clinical outcomes. Now, as Dr. Stiff appropriately mentioned, there's a little bit of a dearth of clinical drug approvals in this disease. These are the historical timeline of drugs approved in the United States and in the EU. We really have essentially 4 drugs right now. 2 of them are hypomethylators, azacitidine and decitabine. One is a IMiD, which is an immune modulator called lenalidomide. You heard a lot about that in myeloma. And then there's an iron chelator. Luspatercept is a really interesting drug that we hope will get approved soon. We'll talk about that. So just to kind of come back to the fact that the MDS population is really heterogeneous, you have to prioritize different things depending on which prognostic group your patient falls in. So for the low-risk MDS, we're talking about survival, a median survival of a decade or so. And so for those patients, the immediate need is more to improve their blood counts, their quality of life, lower their transfusion burden, their iron overload, and survival and delaying disease progression come lower down on the list. Compared to that, the high-risk MDS patient has an imminent risk of transforming to acute leukemia, which would diminish survival. And for them, you really want to delay that progression and improve their survival, and if possible, in the young, fit patient, consider curative treatments, which at this point in time remain an allogeneic stem cell transplant. So talking a little bit about these 2 categories of low-risk MDS and high-risk MDS. Again, the major concerns in low risk are transfusion dependence, bleeding risk, and iron overload. So when we talk about transfusion dependence, it's not just a symptom. So if you're anemic versus your transfusion dependent, it's a little bit different. And this was a retrospective done way back in 2005 that showed quite cleanly that transfusion dependent patients had an inferior survival, which means that maybe it's just a marker of a more severe bone marrow failure, but there are things that come with a transfusion, like antibodies, iron overload, etc., that may be adding to some of the morbidity of needing transfusion. So it's really an important clinical endpoint in a lot of clinical trials trying to improve anemia. So the linchpin of treating anemia in MDS remains the erythropoiesis stimulating agents, the ESAs in short. There are ways to predict which patients will respond to these. Generally, patients who have a low transfusion burden, meaning less than 2 transfusions a month, as well as a low erythropoietin level. Erythropoietin is the hormone your kidneys make that stimulates your bone marrow erythrocyte progenitors to make red cells. If that's low, you generally have a pretty high chance of responding to these agents. About 74% of your score is 0. If, on the other hand, you have a high transfusion burden or a high erythropoietin level of more than 500, the chances of response are significantly lower at 7%. So that may be a patient population that you may want to avoid or do a very short trial. It may or may not work, but the majority it will work if they have a lower score. Now, speaking to a little bit of tailored treatments, there is a subset of MDS patients that have an isolated abnormality, which is the loss of a chromosome, the loss of the long arm of chromosome 5, called deletion 5q. And again, I'm going to reiterate, this has to be isolated and not with other genetic abnormalities. So the original trials that were done with lenalidomide showed that the subset of patients with this isolated abnormality markedly seemed to benefit from this drug, significantly out of proportion to other patients. And so then this patient population was carried forward in a dedicated phase 2 and then phase 3 study to see the efficacy of lenalidomide at 2 different doses, 5 and 10 milligrams, so lower than myeloma doses, and showed pretty significant percentage of patients, about 50%, were transfusion independent for more than 26 weeks. compared to placebo, where it was 5%. And the median duration of response was 115 weeks, so they got several years out of it. So this was pretty impressive and kind of the first targeted sort of approach to low-risk MDS. And so this is a treatment that should be offered pretty early. Having said that, these patients, most of them had an erythropoiesis stimulating agent, so we would still do that first and then go to this. For the patients that don't have a 5q, a trial was done to see in all others, what does lenalidomide do, and the response rates are lower. They're more in the range of 20 to 30%, and the duration is a lot lower at 32 weeks. So this drug is FDA approved specifically for the 5q minus low-risk MDS. Immunosuppressive treatment is another approach in MDS. It's been around for a long time. It seems to work best in patients that have a subset of MDS called hypocellular MDS, which means the bone marrow is pretty empty. This is rare in MDS. Most patients with MDS have a marrow that's full of cells because it's trying to make blood, but because it's genetically abnormal, you have a bunch of cells that are in developmental arrest in the marrow and not coming out into the bloodstream. But a subset actually have a low percentage of cells in the marrow, and there's thought to be some immune mechanisms at play there, which is why they respond to immunosuppressive treatment. So this is a retrospective study that looked at patients from 15 centers that got various immune suppressive agents, and they show that overall response rates were around 42%, out of which 30% actually were patients that got transfusion independence. And when they looked at who responded to immune suppression, actually in multivariate, it really was the patients that had a low cellularity marrow and the patients that got the combination of ATG and cyclosporin. So those were the two immune suppressive drugs in combination that seemed to predict the best outcomes. And patients who responded had a superior survival, which is not surprising. Then there is the hypomethylators, which we'll talk about more in high-risk MDS, but they do have a role in low-risk MDS, an increasing role, I think. So there is retrospective data to show that if you give in a patient with low-risk MDS who has multiple low blood counts, not just low red cells, perhaps low platelets or slightly low white cells, but is still low risk, you can get response rates of up to 40%, 45% in this Italian study. There may be some biomarkers in early development that predict response, because the issue with hypomethylators is it takes about 4 months or 4 cycles to see a response. And so if there was a biomarker that would predict which patients would respond a little bit early, that would be very beneficial. And so there is one that has been studied that is called PIPC, which is phosphoinositide phospholipase C, and that tends to come up in the blood preceding a clinical response, and in the patients that don't respond, it never comes up. So that's something a little preclinical but interesting. MD Anderson did a phase 2 study comparing low-dose decitabine to low-dose azacitidine. Again, we don't know which of these two drugs is better, and they were looking at this in low and intermediate risk MDS, and in this particular study, it turned out decitabine was the winner, and this was low dose, so it was 3 days of decitabine or 5 days of azacitidine. Lastly, the thing about hypomethylators is that they're really changing the way genes are expressed. So in MDS, a lot of genes that tell our cells to mature are silenced. And so the way these hypomethylators work is they have to get incorporated into the DNA and unsilence these genes so that they're now expressed. So the thought is that perhaps a more sustained exposure to these drugs will have more benefit, and that's why oral formulations of hypomethylators are in clinical development and actually in phase 3 testing in low-risk MDS. Lastly, I think the most interesting area, which got a plenary at ASH this year, is the TGF-beta signaling pathway in low-risk MDS. So this is a class of drugs, they're first in class, and Luspatercept is the one that's kind of moved along further in clinical development and is now undergoing evaluation by the FDA for approval. And what these drugs are doing is basically targeting an axis called the TGF-beta SMAD signaling pathway. So essentially, in red cell development, what happens in low-risk MDS is these TGF-beta receptor on the erythroid progenitors, which are the cells that are supposed to produce the red cells. When it binds its ligand, it gets silenced. And so the last stage of red cell development is blocked. And so what these drugs do is they sort of mimic, they're called ligand traps. So they mimic the receptor, but they're not exactly the receptor, and they're floating around. So they trap the ligand so it doesn't bind to its actual receptor, and the SMAD pathway is silenced, allowing that terminal step of red cell production to proceed. Sorry, and that really translates nicely to, in clinical practice, to an improvement in hemoglobin. So this is phase 2 data, but now the phase 3 has also been presented, showing that within 2 months, most patients had a 2-gram increase in hemoglobin. That's pretty impressive, and the side effect profile of this is really good. And it's a sub-Q injection, so it's an outpatient regimen. And so this phase 3 data, which is of the medalist trial of Luspatercept, was presented at ASH, and they showed 37% of patients were transfusion independent compared to 13% in placebo. Having said that, they did select the patient population. So the patients that seem to respond to this class of drugs are the patients that have a morphology called ring sideroblasts, which is something they see in the bone marrow where there's abnormal iron granules in the erythroid precursors, and that usually correlates with the mutation in a gene called SF3B1. So you had to have either ring sideroblasts or SF3B1 to go on this study. So those are the patients that definitely benefit. And what's nice is the pink shows the patients that had a low transfusion burden, but blue shows the high transfusion burden, and this is the transfusion requirement. So it really decreased even in patients that were heavily transfusion dependent, which is often a place where other drugs have failed. We'll also talk a little bit about the thrombopoietin receptor agonists, which are used to treat low platelets. So about 10% of patients have problems with low platelets and bleeding. And so there is a class of drugs approved in ITP to stimulate platelet production by stimulating this receptor called the thrombopoietin receptor in the bone marrow progenitor cells. And so there's an oral version of this called L-Trombopag, which was studied in a phase 2 study called LR-MDS. And the platelet count increased and the bleeding events decreased from 47 to 3%. Was the platelet increase, and 14 to 42 was the bleeding event drop. So, and then there is also a subcutaneous form of this called Romiplastim. However, that trial was halted prematurely, and that kind of speaks to a little bit of knowing the mechanism of these drugs. The thrombopoietin receptor can also be expressed on blasts, which are those primitive cells that as they increase, the disease sort of progresses towards AML. And the early phases of the study showed that those blasts might have been going up with the Romiplastim. So that study was halted. However, there were then extension studies that showed that about 3% of patients developed AML, and 2 out of 60 had a transient increase in blasts. So perhaps not clinically that significant, but I think still something to think about in the patients that have slightly higher blasts. You may want to avoid this. Iron overload is an important issue in MDS. I think the jury's been out for a while about chelation. So iron, there's a lot of iron overload that comes with the transfusion requirement of low-risk MDS. In addition, there's also a lot of ineffective red cell production going on at baseline. So a lot of iron turnover, even without the transfusions. So these patients generally have this as a frequent complication, and the iron can deposit in organs like the heart and the liver, leading to long-term morbidity and mortality. So we've known that for a while, and we've known that iron overload is bad in low-risk MDS. It's a bad marker pre-transplant. But in low-risk MDS, it hasn't really been definitively proven that reducing that iron with chelation improves that outcome. And I think that's where the data is a little bit missing. The Celeste trial did address that a little bit this past ASH. It was presented as an oral abstract. And they basically had patients that had at least 15 transfusions and a ferritin of greater than 1,000. And they got Deferrazerox, which is an iron chelator, or placebo. And they had a composite endpoint, which was cardiac, liver events, and transformation to leukemia. And they showed that the chelated arm did a lot better. Survival, though, I think would be helpful to strengthen the argument to use chelation, and that's going to come in a few years. So at this point in low-risk MDS, the therapeutic algorithm really, and I kind of have talked about a lot of this, so I won't go into it too much, but you're really targeting symptoms, right? Low platelets, you talk about the thrombopoietin receptor agonists. If it's anemia and you have a 5Q, you can use lenalidomide, but you start with the erythropoietin receptor erythropoiesis stimulating agents. And then there's a role for immune suppression in some patients, and then Luspatercept hopefully soon. With high-risk MDS, there is very little room to hesitate on treatment. They generally need something. So when not to treat is not really a question with high-risk MDS, so I'm going to keep this part really short. Essentially, with high-risk MDS, you really want to decide up front if you want to go to transplant. If they're transplant eligible, they should go to transplant. There's perhaps a little bit of a clinical discussion around the fact that should they get some treatment before the transplant or should they go directly to transplant. There's some data showing that if your blast percentage is high, specifically higher than 10%, the chances of relapse are high, so try and get that down a little bit before the transplant. Different centers do it differently. And if you're transplant ineligible, then we have 2 approved therapies, which are the hypomethylators, Vidaza and decitabine. And then beyond that, it's sort of dealer's choice. And there's a few interesting clinical studies that I will touch on in 2 minutes. So the hypomethylators, there was a big cooperative group study by SWOG to see if we improve on them by adding something to them. And lenalidomide or vorinostat were each added to Vidaza versus Vidaza alone because these drugs had shown activity in combination with Vidaza in phase 2 studies. But this is a lesson to us that phase 3 studies have to be done where everybody's treated in parallel on the same study because this study showed that Vidaza alone was just as good. So that was a little bit depressing. But now they're kind of repurposing and coming up with the next generation of studies in MDS. In subset analysis, perhaps the patients with CMML, which is a subset of MDS, the combination with lenalidomide was superior. So in that subset, there may be a role for combination treatment. It's important to recognize that patients after failure of hypomethylating agent have a real unmet need. All these curves are pretty dismal. The x-axis is days. And really, the only curve that plateaus is transplant. This is not the ideal time to transplant a patient, but if you're in this situation and your patient is able and fit and has a donor, it's an option. Second to that would be investigational treatments, which means we have a ways to go. And what are these investigational treatments? So I think this is where, again, the mutational profile of the MDS comes in. About 10% of patients do have a mutation in a gene called IDH2. And in the original studies done with the IDH inhibitor and axitinib, the response rates in those patients were 53%. Granted, there were only 16 patients on that original study that had MDS. Everybody else had AML. But they had hypomethylator and lenalidomide. So it is an option in those patients. The caveat is if you have a RAS mutation or P53 in addition, you're pretty unlikely to respond, so it's probably not worth it in those. And then there are some other agents in development, like a multi-kinase inhibitor called rigosertib, which is sort of mutation agnostic and seems to work in high-risk MDS. Nadylation is another interesting target. So it targets the ubiquitin ligase pathway, which is also what bortezomib and carfilzomib do. So the proteasome is the protein destruction system for a cell to prevent too many proteins accumulating in a cell. And nadylation basically targets that pathway and has shown some activity in AML that evolved from MDS and now is moved back into MDS and is being studied in combination with Vidaza and is in phase 3 studies. So this will be an interesting combination partner with Vidaza. And my last slide is just to kind of summarize a little bit of why I think that the pace of bench to bedside is really kind of picked up. And this is sort of a cool illustration because 60% of patients with MDS have a mutation in a spliceosome gene. Spliceosomes is a complex that basically restructures the RNA. So once the DNA is read, it becomes RNA, and then it has to be kind of restructured and repurposed before it can be coded into a protein. And so these spliceosome genes are one of the most frequently mutated genes in MDS. And it was sort of a mystery about what they were doing in the disease and how to capitalize on that. But from 2013, it was very elegantly demonstrated that basically these mutations generally result in loss of these spliceosome proteins. So there's a lot less of them, and this cell is heavily dependent on them. Because if you delete both genes from a mouse, the mouse has no bone marrow development. So it needs that leftover spliceosome that it's getting from the other genes. So if you can get a drug to inhibit the rest of the splicing proteins, you can really tip these cells over to cell death. And that was nicely demonstrated with a drug called H38800, which is now in clinical testing. So basically, in a transit time from 2013 to 2018, this drug is already in clinical trials in spliceosome mutated patients. And what's really nice about this drug is that when they developed animal models of CMML, they were able to show not only activity, but specificity of this drug. So patients that had the mutation, their disease really went away. The brown cells or the leukemia cells in the bone marrow, they went away with treatment, compared to the second panel where the patient had the same disease without the mutation and had no response. So this is real targeted therapy, and the pace of that advancement is really impressive. So there's obviously a lot of targets under investigation. We've talked about a lot of them, and I'll take questions later. Thank you.